Hello, everyone, and welcome to our Conversations with Professionals webinar series. Today, we're going to be talking to Professor Qasim Aziz and Helen Spriggs, focusing on the GI aspects of living with EDS and HSD. So, Professor Aziz, can you just introduce yourself to everyone, please?
Hello, everyone. I'm Qasim Aziz. I'm a professor of neurogastroenterology at Barts in the London School of Medicine and Dentistry in London. And I'm also in the NHS based at the Royal London Hospital, which is part of Barts NHS Trust. And my experience around research is based around understanding mechanisms of pain in patients with disorders of function of the gut. I'm a neurogastroenterologist, and in particular, I'm very interested in mechanisms of symptoms in patients with EDS, and I've been working on this for about 10 years now, and we now have a third PhD student working on patients with EDS. And therefore, it's an area I find very interesting, very exciting, and I look forward to talking to you today.
Thank you. And Helen?
Hi there, I'm Helen Spriggs. I'm a registered nutritional therapist and I work in private practice at my clinic here in Newbury in Berkshire, but especially with everything that's happened in the world over the last year, I also work online with a lot of patients over video consultation. And with EDS and HSD patients, I really work with them to look at what nutritional status they currently have and how food, and not just the what, but also the how, can be used to perhaps support them and manage symptoms. My interest in EDS has been sparked further as I'm currently studying my master's and just nearly finished writing my dissertation thesis on where EDS is the main focus. So I'm looking forward to that being complete in the summer.
Wonderful. Good luck. So, Qasim, we're going to start with you, please. What are the GI problems that are usually found in the different types of EDS and HSD?
Okay. So I think the basic thing is that the entire range of gastrointestinal problems can occur in all subtypes of EDS patients, but there are some that are more particular to a particular subtype. The most common subtype that we see in our clinic, in fact, 95% of the patients we see are hypermobile EDS and HSD patients. We see very few classical and vascular patients, and also obviously the tenascin X subgroup is very uncommon, but we do sometimes see those. But all the other subgroups are incredibly uncommon in our clinic. So my experience is based around HSD, heads, and some classical and vascular and tenascin X. And the entire gastrointestinal tract, they can present with symptoms of the upper gut, the lower gut, or the entire gastrointestinal tract. So there can be difficulty with swallowing, there can be difficulty with eating because the stomach is too sluggish, so people feel full. They can have constipation, they can have diarrhea, they can have tummy pain, which is quite a common feature, bloating, nausea. All of these symptoms that you would expect are prevalent. However, some of the features that obviously one needs to be very careful about is that if you have a patient with vascular EDS, then you should need to be aware of the risk that these patients can perforate spontaneously. And we have a small group of tenascin X patients who have also perforated. It seems that there is some sort of overlap between the tenascin X patient and vascular patients in that there seems to be slightly higher risk of perforation, but this is based on just a very small number, so I cannot actually categorically say this. But the tenascin X subgroup also has a higher incidence of prolapse, particularly rectal prolapse that we see in these patients. And constipation is a very common feature that we see. And sensitivity in the stomach. And we've done some animal studies, as you know, in tenascin X patients as well. And we found that the stomach seems to be hypersensitive, but the colon appears to be very poor in its motility. But for the patients that we see with HEDS HSD, they can present with one organ system, may predominantly have reflux symptoms or difficulty with swallowing. They may have delayed gastric emptying. They may have constipation with bloating, etc., or diarrhea. Or they can present with the entire range of symptoms. They can have motility problems, they can have sensitivity problems, overlap with POTS, mast cell related problems, etc. So it's really, you have to look at each patient individually and understand what the basis of their problems is, what the basis of their symptoms is. And I think one important thing to remember always is that even though there can be problems with the motility, sensation, etc. in these patients, but also you have to be aware that other organic conditions like celiac disease and inflammatory bowel disease and various other organic conditions which can cause blockage of the gut, etc., can also happen in these patients. You have to make sure that you excluded those before you, proceed further with the management.
Thank you for that. And Helen, one thing that we get asked all the time, and Qasim, I know this has been an area of focus for you, is there a diet for EDS and HSD?
It's certainly a question I get asked quite a lot, and there is no single diet that is appropriate for all HSD EDS patients, because ultimately everybody is an individual, and as Professor Aziz just explained, it depends what else is going on for that individual. Is there the presence of celiac? Is there, is somebody also type 2 diabetic, for example? So it's really understanding for the individual what they have going on and how would be best that would be best addressed. Certainly, I get asked about things like the low FODMAP diet or people following low histamine. They're probably the two that I'm asked about the most often. And something like the low FODMAP, which I know is something Professor Aziz is quite interested in, can be helpful in a certain group of patients. But for me personally, and the way I go about approaching that, it would be for a period of time, an exclusion process, and then it's a structured, very careful reintroduction, because ultimately it's about trying to ensure that a patient is getting as much nutritional variety in their diet as is tolerable for their individual situation. So there's no one perfect diet in my experience that suits all HEDS or EDS or HSD patients. It's looking at that tailored individual approach and perhaps evolving it as an individual goes through a surgical procedure or their medication changes. As some of the symptoms that an individual is struggling with, can they perhaps change as pain medications change? We may see some of their gastrointestinal symptoms change and they need supporting dietary wise. So it's a bit of a sit on the fence answer. There is no perfect solution, but from my point of view, it's really tailoring it to that individual's needs and then evolving it as their needs perhaps change.
Thank you.
I cannot agree more. If I could just come in there.
Please do.
Absolutely, totally agree with what Helen said just then. It has to be tailored to an individual. And I think one of the most important messages, if we can, if our patients can take home from this conversation, is that these diets are not forever. Because the concern is that patients actually, when they go on very restrictive diets, they actually get more and more restricted with what they can actually eat and then develop severe nutritional deficiencies. So structured reintroduction, what Helen said, is absolutely very important, because most patients will be able to tolerate more foods, but it has to be done in a systematic way so that their triggers can be identified, and the ones that are not their triggers can be reintroduced into their diet so that they have the nutritional content of their meals is good. Otherwise, we run into more problems because of nutritional deficiencies.
Thank you. And through the kind of research lens that I know you were beginning to look at, do you think we will ever get to a stage where there is actually a specific EDS and HSD diet that pulls from all of these other diets that we know are used amongst the community?
Helen, do you want to take it, or?
Well, I'll definitely chime in. I think rather than it being a specific diet, that a label is given, I think it will be more a case of there might be some guidelines. Certainly, that's something I'd like to see, or some considerations that a patient can be given guidance on over, is this an appropriate avenue to explore if somebody is particularly presenting with upper GI symptoms, for example, or you have a patient who has GI and POTS and mast cell. There's so much overlap. Nutrition isn't just in relation to only gastrointestinal issues. There's such an overlap between all symptoms. Nutrition is so central to our overall well-being. And so I think this is where there will be a struggle to be, here is a blanket diet that is suitable. But there may be, through the research, and certainly it's something I'm passionate about, more nutrition research anyway, but especially within the EDS world, that there could be some clinical guidelines and suggestions and recommendations that should be considered from a practitioner point of view, and also from an individual patient point of view. But I'm sure Professor Aziz has got some thoughts there as well.
No, indeed, and I agree there, Helen. I think what you said is right. We're not at that stage at this moment in time, I think, to be prescriptive about, this is exactly the diet that every EDS patient should be following. I think this has to be looked at very systematically, and which, as you know, Lara, we are currently doing. The first step really is to understand, what is the range of diets that patients are following. What are the nutritional consequences of those diets in our patients? And particularly in those where we identify that there are nutritional problems that are developing, how can we reverse those nutritional problems? This, I think, is the important need of the hour. And then from there on, through that better understanding, there may be patterns that we recognize. And those patterns then we can develop for, exactly as Helen said, that there may be a certain subgroup of patients where a particular form of diet may be helpful. And we just need to wait for those patterns to emerge. From my clinical perspective now, for instance, I find that there is a subgroup of patients with EDS that meets the criteria for irritable bowel syndrome. They have diarrhea, they have bloating, discomfort, and so on. And for some of these, the FODMAP diet works very well, and especially those who also have bacterial overgrowth in the gut, because of more fermentable carbs cause more fermentation, and they find a benefit from that. But the idea here that I usually have in my mind is to treat the underlying problem in the gut so that they can start to eat a more complete nutritional diet. So especially if they're very constipated, no matter what you do to the diet or antibiotics or anything, it's not really going to work because till you've treated the constipation. Okay, so that sort of stagnation that is going on in the gut, till you've sorted that out, nothing really is going to work. So we focus on treating the constipation, make sure that we manage that, and then so that if they, for a period of time, they do need to go on a low FODMAP diet, and because the constipation is no longer there, we've treated the bacterial overgrowth, then long-term, the gut health has improved. And therefore, they may not need to be on a diet for a certain period of time. Similarly, in patients with mast cell activation type of problem or histamine sensitivity, they often have a very, I find there is a subgroup with a very atopic predisposition, i.e. predisposition to allergies. They often have migraines, they have POTS. So it's just looking at that whole picture there, managing that, looking at the allergies, working with the allergy specialist to try and control that. And when you control that, then the nutritional status also starts to improve. They can start to tolerate more foods that they were unable to tolerate. So it's just not just focusing on the diet, but looking at the whole picture, trying to resolve the gut-related problem, improving gut health, which then allows patients to reintroduce foods and improve their nutrition. So I think that's the approach that we have to take. Yeah,
I couldn't agree more. And certainly what I see a lot clinically is patients coming who have gradually over a period of time self-excluded foods because they feel a certain food exacerbates a certain symptom, whether it's gastrointestinal related or histamine related. And so they find themselves on a really quite restricted, potentially quite nutrient deplete diet. And the aim is always to actually get as much back in as possible, but that can really only be done once we understand the why. Why is somebody reacting in a certain way or finding a food particularly challenging? And as Professor Aziz just explained, over things like bacterial overgrowth and how, if we can address that and look at the microbiome and understand somebody's relationship with food as well, and how that has developed over time. So you have to kind of dig a little deeper. It's not just sort of, oh, if that food isn't working for somebody, cut it out. That isn't for me. And the way I tend to approach, that's not the solution, because you just find that that group of foods gets narrower and narrower, and the risk of further ill health through nutritional deficiencies becomes a significant risk. And that then can lead to the potential perhaps of patients needing severe intervention around tube feeding or TPN even, if that gets to the point where somebody's actually quite malnourished.
Thank you. And Helen, I mean, you touched on the kind of foods that some people may be triggered by. In your experience, what foods should be avoided if people are struggling with those GI problems?
It depends really what GI problem somebody has. Again, is it more upper? So is it that reflux, the nausea, the slow motility with the stomach, and delayed emptying? It's around the what somebody's eating, but also how much, so volume, how well somebody is chewing their food. Even, the basics of chewing makes, a large impact. It's our first mechanical involvement of being able to digest food and add the saliva in, and those digestive juices start to play a role. So for me, it's looking at the what. Yes, perhaps we need to be avoiding for some very spicy foods or very rich foods, because they can be, or foods that are very hard to digest. Say, especially if we've got that kind of upper GI involvement. Then if we're looking at more lower GI involvement, actually is somebody having an appropriate amount of fluids or fiber, or too much fiber, and that becomes exacerbating to their symptoms. So again, there's no golden rule of avoid these foods. I have people that come to me that say, I eat healthily, I eat the brown bread options, and that makes me feel worse. So I go back to my safer kind of white bread options. And it's understanding why that's happening for somebody, so that we can perhaps then reintroduce foods. So there's no I spend a lot of time sitting on the fence, I suppose, saying there's no one set of foods that people should be avoiding. My biggest goal really with people is to make sure they're eating as real food as possible, rather than highly processed, often nutrient deplete food. It's about having people get as much nutrition as possible through their diet, and then allow their body the opportunity to digest and absorb it. Obviously, for some people there can be challenges, but thinking about timing, are we eating food very late in the evening, for example, and that's putting extra pressure on the digestive system, or eating in a hurry, not being very engaged with food. It really can impact on the way that somebody's digestive systems can cope with food. So it's the what as well as the how we go about engaging with our foods I really advocate for, I suppose.
Thank you, that's really helpful. And Professor Aziz, you touched on when you were speaking earlier about what I think are the three main things that we hear from our community in terms of symptomatic issues, and that's abdominal pain, nausea, and constipation. And so, in your experience, what are the usual things that are causing those three things?
I think the important thing is that all three symptoms are multifactorial. Okay. And it requires careful listening to the patient, careful evaluation of the trajectory of these symptoms over a period of time, to really understand what the process and what the mechanism could be. And I just take the example of nausea. It's such a common symptom, but it can actually occur as a consequence of problem anywhere in the body. Nausea does not have to be a gastrointestinal symptom. Okay. You have a urinary tract infection, you can actually get nausea. You have inflammation anywhere in the body, and pain anywhere in the body, that can cause nausea. Medications can cause nausea. Okay, but in fact, nausea is the most common side effect of medication. So one has to really evaluate the mechanisms. But just talking about some of the common ones that we see that are gut related causes is in the upper gut, it's delayed gastric emptying. Okay, if your stomach movements are slow, you have gastroparesis. Nausea is a very common symptom there. It's often associated with fullness. People cannot finish a normal sized meal. What's called early satiety, that they have to stop mid-meal because they feel too full. Or if they are able to finish a normal-sized meal, they feel excessively bloated and full after that. And nausea is a common symptom that will occur in these patients. If you actually move down the gut, this motility in the entire gut, in the small bowel, in the large bowel, etc., which causes stagnation. Stagnation is often associated with altered gut microbiota, small intestinal bacterial overgrowth, and nausea is a very common symptom of small intestinal bacterial overgrowth, as is abdominal pain. Especially in the elderly, nausea and vomiting can be a consequence of constipation. And nausea can be a consequence of any gastrointestinal disease, especially not just related to EDS or motility or sensitivity problems. It can be a feature of celiac disease. It can be a feature of inflammatory bowel disease. It can be a feature of certain types of cancers and so on. So one needs to do a proper evaluation. But one thing, once you've excluded all these other problems, one of the other common causes of nausea I see in my EDS patients is POTS. Okay, so postural tachycardia syndrome, because they are running on a relatively low blood pressure, heart rate is high, so the sympathetic nervous system, your fight and flight nervous system, is hyperactive in these patients. And nausea can be a consequence of that, the altered function of the autonomic nervous system. This is the nervous system of the organs of the body. Now, just to remind people, your fight and flight nervous system, also called the sympathetic nervous system, when that gets activated, the heart rate goes up. And that's the common problem in our POTS patients. They have high resting heart rate, and with exertion or with change in posture, heart rate goes even further up. Now, the fight and flight nervous system in the heart is stimulatory. In the gut, it's inhibitory, because when you're in that fight and flight mode, you don't want your gut to be very active. You want your gut to go quiet. So nature makes the gut go quiet. So the stomach movements, the small bowel movements, etc., all slow down. Okay. So, and if this becomes a chronic situation, then your stomach emptying and small bowel movements become chronically slow, and that can be a consequence of nausea. So quite often I find that when you treat POTS and the heart rate comes into control, the sympathetic nervous system comes under control, nausea improves. And early morning nausea, when I actually often ask my patients, how often do you get nausea? And when I hear that it's 24/7, of course it gets worse after meals, but it's actually present irrespective of meals, and it's present first thing in the morning when they wake up. I often then ask them about POTS, because I find this to be a common symptom in POTS as well. And that's where I would actually, if they're not under a specialist for the treatment of POTS, I will often refer them for the treatment of POTS. And it goes on the same way about pain. There are multiple mechanisms of pain in the abdomen. It could just be that the gut is sluggish, it's overloaded, there's bacterial overgrowth, and increase in sensitivity in the gut. But also we find pain in patients who have increase in mast cell activity or histamine reactivity, food sensitivity, severe constipation. Abdominal wall pain is something that I'm very interested in, because I find that a third of patients that I see in my clinics with EDS, because their core strength often is not so good, they overuse their abdominal muscles to stabilize their core. And because of that, they get almost like a repetitive strain injury on the abdominal wall muscles. And that can cause these fibromyalgia-like trigger points on the abdominal wall, which can become very painful. And sometimes they get trapped nerves in the muscles, because there are some nerves that go through the muscles of the abdominal wall. They can get trapped, and you can get very severe pain because of that. So I always look at that, which is often missed. This cause of pain is often missed. And then there are some uncommon causes of pain, which we picked up, especially very severely ill patients where pain is just so severe, they just cannot eat, etc. I always try and make sure that we've ruled out conditions like intra-abdominal vascular entrapment syndromes. What we mean by that is that one blood vessel is compressing another blood vessel. A common one is the superior mesenteric artery syndrome, where one of the arteries of the aorta, called the superior mesenteric artery, the gap between that and the aorta is narrowed, and it catches the duodenum between the two blood vessels. So you not only get an obstruction type of picture with gastroparesis type of picture, but you also get a lot of pain from that. And there are 3 or 4 other conditions like that. And we've actually picked up some of our EDS patients with multiple vascular entrapments in the abdomen. So particularly in young girls, which is a more common scenario that we see, I would often get a CT scan or an MR scan just to exclude that, and other organic causes of pain as well. Constipation can be due to transit problems. Things are slow to get from A to B from across the colon, or it can be a problem of evacuation. The pelvic floor muscles are not moving very well, or the rectum is prolapsing internally, or you're getting a pouch in the rectum called a rectocele. So all of these factors need evaluating. It's just someone who says, okay, I have, even if I feel the stool in my back passage, I have huge problems in evacuating it. I just have to sit for hours trying to evacuate it. There's obviously a problem with the evacuatory mechanism. We need to assess that and manage that. So I think simplistic answers is not the way forward in these patients. One needs a careful evaluation because symptoms can be multifactorial. And that's why I do, again, through this forum, I apologize to my patients when you're waiting in the waiting room because I'm running 1 hour late, is because of this, that, even though I allow, 45 minutes to 50 minutes for my new patients, sometimes that's just not enough when there are so many interlinked problems. So it's just that careful evaluation that is required in every patient.
I think we're incredibly grateful for your thoroughness and experience in this. I think the wish is that there were just more GI specialists out there that could look at our patient community through that same lens and understand all those different things to rule out. And I think that's where a lot of frustrations come with people that are not being evaluated in that same thorough way. So thank you for all the time you're taking on our
pleasure.
patients. Helen, I think a big thing as well that's often discussed in forums and on social media is supplements. And I think that, for me personally, for example, high dose vitamin C has completely changed my quality of life, but people don't know how how much to take and in what form. And so in your experience, what kind of supplements are helpful, but equally, are there any particular supplements that you see make problems worse?
Yes, like as you rightly said, supplements is a very hot topic, and they absolutely can play a really crucial and helpful role for some individuals. You mentioned vitamin C there, certainly can be really helpful when we're thinking about this particular patient population. But conversely, too high a dose of vitamin C, which is totally individual, we can reach what's called sort of bowel tolerance, and actually we could see it contributing towards a much looser bowel movement. So too much in the wrong person could absolutely trigger either a new symptom or exacerbate an existing symptom. Same can be the case with certain forms of magnesium. So magnesium citrate, for example, can again exacerbate a loose stool situation. So when you see recommendations on forums, people discussing certain supplements that have worked for them individually, great. That's great to try and understand why that's happening for that person. Is there an opportunity to actually obtain that dietary wise as opposed to from supplements? Or understanding that just because it's worked for one person, even somebody who appears to have a similar set of symptom presentation, it could have a really different effect in that person. And within that, there can be lots of reasons, because somebody obtains a different format of that particular supplement. It's delivered in a different way. So is it a capsule, or is it a powder? Is it a sublingual drop? Is it a patch even? And also we have to be really careful thinking about supplements around interactions with medications. People think that food supplements are safe, and whilst yes, of course, they've gone through testing to make sure and the dosages are capped, we do have to think very carefully about the interaction between certain medications and certain supplements and certain foods as well. Probably the most well-known is grapefruit. Most people on a whole selection of medications would be advised to not take grapefruit as in a food state, or there are certain supplements that would involve grapefruit, and that's because they interfere with how a medication is processed in the body, potentially making it be processed much quicker or much slower, which essentially alters the dose that you would be receiving of that medication, which could be significantly impactful. So my advice always with supplements is to make sure you're doing it with the guidance of somebody that can discuss your whole situation and look at things like what medications you may be taking and what your symptoms are, and discuss, I discuss with people who come to me already with a big supplement stack almost. Why are you taking this? Have you had a vitamin D level checked, for example? Certainly vitamin D is something I see often low in the EDS patients that come to see me, and that can be down to a number of reasons, perhaps because they're not spending a huge amount of time outside, and or maybe there's other factors at play around the genetics of how we actually make vitamin D. I won't go into that. We need to be able to understand, well, what is somebody's level of vitamin D to understand what is the appropriate dose of vitamin D that somebody should be taking, rather than just taking, a standard off the shelf from a supermarket or a pharmacy or a health food shop. For me, it's about tailoring, because ultimately what we also don't want to have is somebody taking 10 or 20 different supplements, which I have seen people on huge, very, very expensive supplement protocols, but that's almost replacing food in their mind. And for me, it should be food first. And if we need to think about therapeutic doses of certain supplements, like you mentioned, Lara, vitamin C, for example, can be really helpful. But it is how much can we get from our diet first, and then top up with supplements if it's appropriate. And again, maybe not forever. Maybe it's as a short-term intervention, and how we deliver that in the body. So if somebody is having absorption issues, as a short-term intervention, can we perhaps look at delivering it through an oral spray or a sublingual drop because we don't have to go through the digestive process so much. We can actually get something into the bloodstream quicker, so we can support cellular health. So there's lots and lots of different things to consider, and I'm really passionate about making sure that people are not just going, well, I take a supplement, therefore I don't have to look at my diet, because it should always, where possible, come from food first, and not restrict there just to be able to take a supplement, because you don't know what's in some supplements. They're readily available, and lots of the excipients and fillers sometimes can actually cause problems, or the dosages are very, very low, and there's lots of other things mixed in. So it can be a bit of a minefield, I appreciate, but I tend to encourage people to look at supplements as they would a medication, thinking about, I need to get some professional guidance over what's appropriate for my own situation, so it can be done safely.
And obviously EDS, connective tissue. One supplement that comes up a lot in question is, will collagen be beneficial? What's your thoughts on that? So
for me, if somebody reports that they have done well taking a collagen supplement, and some people I have had say that yes, they have, then we have to think, actually, can we increase those base nutrients through our diet anyway? Now, again, where we have to think about somebody's access to food, somebody's capabilities around cooking and preparing food. So sometimes a supplement can be helpful, but if somebody is doing well by supplementing collagen, then my thought process would be, well, let's look around their protein intake, let's look around their vitamin C intake, and can we support that? So we're going with the food first, because ultimately a collagen supplement has to get broken down through the digestive process anyway, for the body to reprogram it back into that collagen. And obviously, it depends on what type of collagen we're taking, the quality of it, what type of EDS we're talking about as well, over what type of collagen's involved. So again, it's not a blanket take it and it's definitely going to help, because some people absolutely find that it doesn't make any difference. I would always look back to food first if somebody reports that they did well taking a collagen supplement.
Thank you.
I'd love to know Professor Aziz's thoughts on that one.
No, I agree with you. Food first, try and get your nutrition as best as possible, and use the supplements, as a adjunct if needed. And I also see some patients coming in with just a huge list of supplements, and you just really wonder how much benefit they're actually getting from it. And there's obviously a huge expense associated with it. And some patients are very sure that these supplements are making a significant difference to them, and that's quite reasonable. But when that evidence is not really there, and there's just taking these supplements without necessarily gaining benefit from it, one needs to really look at whether the nutrition can be improved really in a way that some of these supplements may not be necessary anymore. But Lara, like you, I find vitamin C very helpful as well in some of our patients, particularly those who are bruising quite a lot. Vitamin C helps there. Vitamin C helps to some extent in patients with histamine sensitivity, reactivity. There is some evidence that it helps to stabilize mast cells and reduce histamine sensitivity, and has a beneficial effect on allergies. So yes, there is, there are some well-known reasons why vitamin C might work in a group of patients. But there is still a lot of variation that in others, vitamin C, as Helen said, can cause diarrhea, and they don't tolerate it at all. So we have to be aware of all those variations as well, and be a little bit cautious in prescribing these. I often inform my patients that yes, vitamin C can be tried, but these are the possible side effects that you might might get, and you might just want to be careful. And also high doses of vitamin C, you have to drink a lot of fluid because it can be associated with oxalate stones in the kidneys as well. So fluid intake must be kept very high if you're taking regular and high dose of vitamin C.
Thank you. Thank you both on that. Professor Aziz, are colonoscopies, endoscopies, and other diagnostic tests safe for those with all the different types of EDS and HSD?
Look, hypermobile EDS and HSD, I can say categorically that they are safe because we routinely do them, and there are one or two studies. There's one study come from Maastricht where they actually specifically looked at HSD and HEDS patients and did not find any risk of any complications. In fact, it is interesting that it is suggested that colonoscopy is more difficult in HEDS patient, HSD patient. They found actually when you look at it objectively and actually study it in a research setting, there was no difference in the difficulty of colonoscopy in a HEDS HSD patient versus non-HEDS non-HSD patients. So that's, I think, reassuring in some respects. So for these patients, we wouldn't normally be worried. The risk would be about the same as anyone undergoing a colonoscopy. But of course, for vascular ones, and I think to some extent with tenascin X patients as well, one needs to be, with vascular ones, we need to be very cautious because there is a risk of perforation in them. And if we can actually do other investigations instead of a colonoscopy to get the same answer, then that should be possible. For instance, a CT virtual colonoscopy can be done. So with a CT scan, you can do a very good virtual colonoscopy without actually putting a tube in. So one needs to look at that. With classical EDS, there isn't enough data for us to be categoric, but I would still advise caution. One has to be convinced that the colonoscopy is definitely needed, categorically needed, and then the colonoscopist needs to be informed, and they have to be very, very careful with that. But we don't have really good, strong data as such to say that there is definitely a very high risk, but I would certainly advise caution. And all the other subgroups, we just don't know enough about them. They're just not been studied. But of course, if there is no history or incidence in those subgroups of EDS patients of visceral perforations, etc., then I think cautiously endoscopies, when they are absolutely needed, can be done. But again, in the knowledge that the patient does have EDS, and therefore all necessary care is taken during those procedures.
Thank you. Helen, do you see more allergic reactions to food in those with EDS and HSD?
I definitely see those with EDS and HSD with allergic reactions. I think it's really important for some patients, they come with the understanding that they have an allergy, but it's really key to differentiate between an allergy and an intolerance, which sometimes the terms get used a little bit interchangeably. Is there a true immune response, an immune reaction to a food, but also an environmental or chemical that somebody may be coming into contact with? Or are we talking an intolerance where the body is not able to digest and break something down? So we're seeing a more gastrointestinal involvement. But I definitely do see patients with a variety of allergic reactions, things like egg I seem to see quite a lot of, but then I have people coming to me saying, I'm allergic to dairy, but actually it's perhaps more of a dairy intolerance or a lactose intolerance. So it's really key to try and understand that. And from then my point of view, it's about having that sort of multidisciplinary approach. So having a referral to an allergist, having a referral to obviously somebody like Professor Aziz from a gastroenterology point of view to understand and make sure that the individual has had the appropriate investigations, rather than just assuming that there is an allergy because it's a self-reported. We need to understand what that actually is. You know, if it's a nut allergy, is it all nut, or is it just a certain nut or certain, you know, selection within the nut group? So for me, I wouldn't be in a position to diagnose the individual. Yes, I can support them once we have that piece of information, but it's about making sure that there's a clear understanding of if it's an allergy, if it is an allergy, what specifically, or if there's an intolerance, and then being able to support somebody appropriately. Because again, if somebody feels as though they react to a food, it's why. And what we don't want to do is just gradually exclude things with no firm basis, which obviously could potentially lead to further complications or nutritional deficiencies.
Thank you. That's helpful. Professor Aziz, how are prolapsed rectums and other organs diagnosed and treated?
Okay, so there are specialized investigations for this. We do a range of tests in patients with bowel problems called anorectal physiology tests. Okay, this involves 3 or 4 components. One is a transit study. You just they swallow some capsules which are visible on an X-ray, and you take an X-ray 5 days later to see where they are in the bowel, and if they're scattered all the way around the bowel, that means that there is slow transit. If they are more on the left side of the bowel, and particularly all of them or majority of them focused around the rectum, that gives us a clue that there is a problem with evacuation. That in 5 days, when you take an X-ray after swallowing the capsule in 5 days, most people should have eradicated most of those capsules. But if they are all mostly on the left side of the bowel, and particularly in the rectum, then we worry about evacuatory dysfunction. Now, then the second test we do is anorectal manometry. Manometry is a measurement of pressure waves in the rectum and in the anal canal. So there's a small catheter, a small tube, which has got pressure sensors that's placed in the rectum, and we measure the movements of the rectum that denote what we call peristalsis. And then we can actually, there's a balloon attached to it, we can measure sensation, because in some people, the problem that they can't evacuate is that they don't sense the stool very well. They don't sense it until a large volume has accumulated in the rectum. So it's almost like a nerve dysfunction in the rectum that doesn't allow them to sense the stool, which eventually means that the rectum becomes a bit bigger in diameter and becomes inefficient in its function. There's something called megarectum can occur. So that's often an indication for us that if they're not sensing it, that there will be dysfunction in evacuation, and they will be straining when they're trying to evacuate. And another consequence of poor sensation is that they evacuate a small amount and they lose sensation to evacuate any more. So stool keeps on accumulating in the rectum. We also use the balloon to see if when we distend the rectum, there is a natural inhibitory reflex which relaxes the sphincter muscles and the anal canal. And this is a reflex which is mediated via the spinal cord, and people with spinal injury and other spinal diseases, this reflex is not present. So that when you distend the rectum, the anal canal and the sphincter muscles don't relax. So this is another thing that we would look at. And then the final test, which will really tell us about prolapse, is a evacuation proctogram. This can be done through a straightforward X-ray, which is our preferred method. Can be done in an MR scan as well. And what you do is you put some contrast, like barium, in the back passage, and then for the X-ray method, they would sit on a commode, which has got an X-ray machine attached to it. And during that evacuation process, we see whether the rectum is prolapsing. So what you see is the rectum sort of collapsing down on itself. Instead of squeezing the stool out, it flops down on itself and produces an internal prolapse. It may not come all the way out, so people don't realize that they're getting a prolapse because it's an internal. And the classical symptom with that is that they may be able to start passing the stool, but soon afterwards, they feel a blockage. They can't get rid of the rest of the stool, and they strain and strain, and the stool doesn't come out, and they have this feeling of incomplete evacuation. Another problem we see is a rectocele, which is a pouch that forms in the rectum from repetitive straining over a period of time. And that repetitive straining then leads to bulge forming in the rectum, and there's a pouch that develops. And the consequence of that is that as stool passes over that pouch, it drops down into the pouch. And that leaves you with a sensation, even though you might get rid of the rest of the stool in the rectum, but that leaves you with a dissatisfaction. There is something still there and I can't get rid of it. Okay, so that's an anatomical problem that we see. In some patients, the whole pelvic floor muscle apparatus is not working in a coordinated way, or the sphincter muscles are not relaxing, a condition called anismus. So there's a whole range of problems that we see that we need to diagnose those. And only then, once we know exactly what is happening, we can develop a management plan around that. And quite often it will involve helping patients to improve the pelvic floor function by sending them to a colorectal specialist nurse or a pelvic floor physiotherapist who will work with them to improve their pelvic floor function and advise them on how to strain, how to breathe during defecation, how to position their legs during defecation, etc. And that may, in its own right, be very, very helpful. In some cases where there's a big prolapse in the rectum or a large rectocele, surgical correction of that is required, and that can be sometimes quite helpful. The slight risk of that is that these prolapses can potentially recur in the future. So one has to be a little bit careful. So you try conservative measures as much as possible to, in the first instance, to try and manage them. And one can help the evacuation process through the use of suppositories, small enema, called a microlax enema. In some patients, they require the standard phosphate enemas or fleet enema. And in some cases, they also require rectal irrigation to help evacuate properly. So, but again, it really depends on an individual subject as to what their requirements are going to be. And you need to work in an MDT team. So we work together with a colorectal specialist nurse. We work with colorectal surgeons. We do MDT meetings. And there's always a radiologist involved who helps us to interpret all the radiological investigations. And between this group of MDT sort of colleagues, we make decisions about complex cases and try and help them in that way.
Thank you. Helen, and I think I'm going to have to come to you, Professor Aziz, afterwards for your opinion, but starting with you, Helen, what should when should alternative forms of nutrition, such as an NG tube or TPN, be considered? And do you find that these are commonly needed in people with EDS and HSD?
They certainly have their place, and obviously for some people it's an absolute necessity. From my point of view, if I would refer somebody back within their gastroenterology team to there's usually a dietitian within somebody's team to be able to make sure that appropriate levels of nutrition are being delivered. Within my role, I have my very strict professional guidelines and my own scope of practice that I wouldn't directly work with somebody who was using, who was on TPN or a tube feed, because of the sort of professional guidelines around that. But yes, it is obviously seen, and certainly I've seen people who have previously been going through that process and have been able to then, with a lot of support, with appropriate support, actually then transition back to eating. But it's understanding why does somebody need that level of support, and is it a temporary, is there a process, what's the roadmap for that individual laid out within their specialist team, and to make sure that if somebody has previously been under that very strict regime of making sure that around swallowing, or essentially retraining how somebody should go about eating, and that there's a very structured guided process of reintroduction of foods through liquid, blended, soft foods, rather than something that's going to be very difficult for the digestive system to deal with. So on that, I can probably defer to Professor Aziz, who can give some additional medical input there.
So absolutely concur with Helen. First, you need to make sure what can you do to optimize their oral nutrition. And sometimes some supplements are required, and sometimes we use, when patients sometimes come to us at a stage we're not really tolerating anything, and volume seems to be a problem. For whatever reason, there is a problem with volume, and sometimes it's difficult to understand what the reason is, because the gut seems to function okay when we do the test of motility, etc. There isn't a severe restriction of movements, but still the tolerance of nutrition is quite poor. And we try all the measures that Helen mentioned, and sometimes we use sip feeding, that you just try and sip throughout the day, liquid liquidized food, or liquid supplements. But sometimes we get to a point where the BMI and weight is just at such a stage associated with nutritional deficiencies, where objectively you can see that there are nutritional deficiencies that have actually developed, or malnutrition that has actually developed, that for a period of time supporting nutrition in the form of either enteral nutrition, which is nutrition through the gut, or sometimes when the nutritional problems have become so critically abnormal that they're becoming life-threatening. And hopefully before that stage is reached, that for periods of time we need to use intravenous nutrition. This is often short-term to try and overcome this nutritional deficiency, look into what's causing the nutritional problems, look into what's causing the symptoms, try and deal with those, while at the same time making sure that nutritionally the patient is safe. Now, in some cases, and one of the issues is how common is it that you require long-term nutritional support, and it is not so common. This is really in some ways the tip of the iceberg, where you need long-term nutritional support in the form of either intravenous nutrition, particularly in the form of intravenous nutrition, but also enteral nutrition. And the subgroup where it is required is where they've developed more like an intestinal failure type of picture, that they cannot obtain nutrition, they cannot maintain nutrition through enteral feeding, through feeding orally or through the gut. And that subgroup is a small subgroup. And there is a small overlap with a condition called chronic intestinal pseudo-obstruction. That is uncommon. Severe intestinal dysmotility is somewhat more common in this subgroup of patients with intestinal failure, and sometimes we don't understand the reason for intestinal failure. But through repeated efforts to try and maintain nutrition orally, if that has failed, then it's reasonable to think about parenteral nutrition, which is intravenous nutrition or nutrition through the gut. But we're also aware of the fact that this group of patients doesn't do very well on those forms of nutrition. There is a higher incidence of complications with infections, line infections, and we know that if you've got an intravenous line going straight into your heart, if you get an infection, that can have very serious consequences. And sometimes infections are the most common cause of mortality in that subgroup of patients, which have to be managed very, very proactively. So these decisions are not easy to take. They have to be taken in an MDT setting, where a group of experts, physicians, nutrition specialists, nurses, and quite often psychologists and dietitians and nutritionists need to work together to find the best solution for that patient. So it is required. The answer is it is required. It's not the most common scenario. The most common scenario is that you can maintain nutrition orally and manage the symptoms to a very satisfactory rate, but these forms of nutrition do become necessary in a small subgroup of patients.
Thank you. And the last question to both of you, you both touched on swallowing. How are the swallowing disorders diagnosed and treated, and can they improve? And we'll start with Helen.
So from a diagnosis point of view, then if someone were to present with me with swallowing issues, then I would make the referral out to the appropriate specialist to make sure that swallowing studies could be undertaken or appropriate investigations. If somebody has been given the all clear that there is no structural reason behind an impairment to that swallowing, then we have to consider what somebody is trying to swallow, how they're engaging with food, but also thinking about somebody's relationship with food. Is there a fear? Is there an anxiety around actually swallowing and eating the food because they're concerned they may feel nauseous, they may feel as though they're actually going to vomit, or they're going to end up with tummy pain or a headache? All of those factors can influence actually our ability to swallow. So from my point of view, it's thinking about all of those and understanding somebody's relationship with food. And perhaps there may be the requirement to bring a specialist in to address some of the psychological factors around somebody's relationship with food, alongside gradual increase or challenge over texture and flavour of the foods themselves, to make sure that somebody's capable, and it can be a gradual process.
Thank you.
Yeah. So from my point of view, when those assessments that Helen has mentioned have been done, what I want to make sure is that there isn't any physical reason for that difficulty with swallowing, especially when the patients say, well, I actually feel as if the food is stuck there in my esophagus, in my food pipe. Then we need to absolutely make sure that there is no physical cause of that obstruction, and we would need to do a camera test endoscopy to make sure that there is no physical cause. And when we do the endoscopy in someone who's complaining of difficulty with swallowing, I will always ask my colleagues to take a biopsy from the esophagus to make sure that there isn't a condition called eosinophilic esophagitis, which is when allergy cells called eosinophils infiltrate the esophagus and make it very stiff, and that causes difficulty with swallowing. So if those causes have been ruled out, then we would do an assessment of the function. So the endoscopy looks at the structure of the esophagus. We would then make an assessment of the function of the esophagus. And there are two ways to do that. A simple way, which is available routinely in most hospitals, is just to do a barium X-ray. So you swallow some barium, which is radiopaque, and you take some X-rays, and you can get dynamic images of the esophagus as it moves the barium down. And then you can see whether it is able to move it down adequately, or it is very slow in moving it down, or the barium is getting stuck. And you can dip some bread or a marshmallow in barium and swallow that to see whether the solids go down well in the esophagus or not, how long they take to go down, etc. So those sorts of basic tests can be helpful. Then more sophisticated physiological tests involve doing a manometry. Manometry is again measurement of pressure waves in the esophagus using a catheter, which has got lots of pressure sensors, which you place in the esophagus, and then you do liquid and solid swallows and actually see whether the movements are normal or not. And the most common problem that we see in our hypermobile EDS and HSD patients is that the motility, the movements of the esophagus are a bit sluggish, and they are not something called ineffective esophageal motility, that the pressure waves that are generated by those movements those pressure waves are quite low. Mostly that allows patients to clear the esophagus of the food. There may be 1 or 2 attempts that are required, or a little sip of water that is required to actually get it done, but mostly they will clear it. Occasionally we find that the motility is quite delayed and they're not able to evacuate adequately. And therefore you can then, if you are sure that there is no underlying problem and this is only related to EDS, then we can give motility stimulants like domperidone or metoclopramide and so on to try and stimulate the esophagus to move it better and improve the peristalsis.
Thank you. And in your opinion, all of these things that we've discussed, is there hope that they can improve? And I'll stop, Helen.
Ultimately, it's always my desire when I'm working with an individual that we can improve their nutritional status, that they can improve the variety of foods alongside an improvement of symptoms. For me, it's really important to get people just to a point of actually consuming appropriate nutritionally dense foods. For some people, they could be starting at a very nutrient deplete state, and so it's not about using a specific EDS or HSD diet, as we spoke about earlier. It's actually just getting a good baseline of nutrition in, and that in itself, for some people, you then start to see an improvement of symptoms, whether it's more complete bowel movements, whether it's actually influence around fatigue and energy, and then somebody's ability to actually go on and prepare food because they actually have more energy to be able to do that because they're getting a better level of nutrition in. For some people, it's much more a narrow sort of therapeutic interventions because they're already at a good level of nutrition going in, but it's understanding a specific symptom and how we can look to support that nutritionally. But ultimately, I do see improvements in patients with not just their gastrointestinal symptoms, but overall, if we can understand why a symptom is there in the first place. If there is a severe overgrowth of bacteria in the small intestine and we're just flooding the body, flooding the gastrointestinal with the things that those bacteria love, then we're not addressing the problem, or we're just trying to patch a symptom around bloating or pain. We need to understand what the cause is and then work with other professionals and look at somebody in a holistic way to be able to address the sort of deep-rooted cause or contributing factors at least. There is no single cause for somebody with some of these symptoms. As Professor Aziz noted earlier, a single symptom like nausea can have so many reasons behind it, and somebody may have more than one reason why that symptom is presenting. But if we can take the pressure off the system by addressing what and how they eat, then we can perhaps see some improvement, and we can see what's left to be able to work with, especially from a multidisciplinary approach. It's something I really advocate for, and I advocate for the people I work with, of trying to get the rest of their care team involved to address these things across the board, not just from an individual perspective.
Thank you. And
absolutely, Lara, that is the aim, to make people better, and that's what we strive for day in, day out. And I think it requires that level of commitment between ourselves and the patients to work together and actually support each other, help each other to try and achieve the desired aim, which is to improve. And I have to say that our EDS patients are just lovely. They cooperate, they listen, they give good feedback, and together we sort of work out over a period. Sometimes it can take a little bit of time because there's so many things, as Helen said, there can be so many multiple reasons for a particular symptom: nausea, abdominal pain. I sometimes see patients with 3 different causes of pain in the same patient, and you have to work out the mechanism for each one of them and then management for each one of them. The same patient who has bacterial overgrowth also may have abdominal wall pain, and then there could be another reason. There may be some inflammation somewhere, or a motility problem, or a sensitivity problem, etc., or a mast cell problem. So all of these things are, they can be multiple reasons, and working through these can take a little bit of time, but with patience, and sometimes patients might find frustrating, oh, professor is asking us the same questions again in this next consultation as well. And it sometimes takes a little bit of time to just completely understand the whole sequence of problems that are actually occurring in a particular patient. And as you build up that knowledge base about the patients, you start managing and treating the individual causes and so on. I would like to say that in vast majority of patients, we do see an improvement, but most importantly is educating our patients to understand that process. They understand the reasons why they develop problems, so that they can also self-manage themselves, recognizing that, oh, they're taking 3 medicines that are contributing to some of the symptoms they're experiencing, that are contributing. So the medicine they're taking for their nausea is actually causing constipation. And the constipation is becoming so severe that it's actually then causing nausea. So those vicious cycles need to be broken. And that education, that sort of knowledge base that our patients need, is something that is required, and it takes a bit of time, but it works. It usually works, and we are able to get things moving forward and improving our patients.
Well, thank you both so much. I think I could go on for another 2 hours asking questions that we know are so relevant to community in this area. But thank you both for giving your time today and for everything that you're doing for our community. We are truly grateful. And thanks to everyone for tuning in. We hope that you found this really helpful, and we will speak again soon. Thank you.
Thanks, Lara.
Thank you very much. Thank you. Pleasure.